the second part. Okay, the second part has to do with models of care and integrating informal care. Now, what is this whole thing about? Now, you know on this course, Continuum of care, it's really about integrated care, right? So you have lecturers talk about home care, lecturers talk about making integration happen. That was last week. Then today's informal. Then you will have talks on, say, nursing home or residential care. Then you will have another one on, say, community care. Right? We have a whole spectrum of this. Care is what is focused on the supply, right? That means care professionals or healthcare workers providing something, either a service or a program. That's care, right? We are less focused on the demand, right? That means people using. It's like I can sell my handphone, you may not want to buy it, right? I can set up my online store on Carousel and Lazada and so on, right? You may not want to buy it, right? So here, I would like you to see that models of care really focuses on service provision. It's nothing to do with utilization. That will be the demand. Okay. Of course, they are related. Of course, demand means supply. That's where the price is in a free market mechanism. Of course, we know that, right? But I'd like you to understand that so far our models of care have very much been focused on, at least right to my knowledge till now, right, provision of services, whether it's clinical, whether at the individual level or organization level or at a societal level or policy level. You have probably among the 10 readings I saw that Joseph gave you. You have this one from Pim Valentine on primary care and the various types of integration, functional integration. You have the meso, macro, and what else? Micro, meso, macro, chrono. That's an article written by Pim Valentine who now works for IFIC, International Foundation for Integrated Care. That is a good article. I encourage you to read it if you haven't. It talks about different kinds of integration: functional integration, clinical integration, service integration, organizational integration. The four types, right? And this, in that article, right, this idea that these various types of integration, right, when achieved, helps us arrive at a different model of care provision. Right? So integrated care is a model on its own. Right? Now, the other perspective I'd like to bring us into when we talk about this topic, and then probably we can go for a break in about 15 minutes, is this. So far, there doesn't seem to be much talk or description on where or which part or which space informal caregiving falls into in many of these models, major models of care. Right? Where do we put FDW? So I'd like you to think about things like this in this second part. Family members interface with healthcare can be really multi-pronged, anywhere from primary care GPs, right, practitioners, to acute hospital, right, to specialist operation, special SOCs, we call them in Singapore, specialists of what do you call it? Okay, yeah, okay, that's a mouthful, right? And then when long-term care is concerned as well, right? Day rehab and various places, they have the various touch points there. Where do we really place informal caregiver? Where should informal caregivers be best placed? Where are they best placed? With what skill, whatever skill or knowledge that we want to give them, or that we hope they will acquire somehow through training, through experience, through whatever, where should they be placed? Because if they are supposed to be, let's say, best placed to work together with GP, let's say, then let's not say spend too much time and resources and subsidizing the other type of training. Let's just train informal caregivers on working with GP in the primary care setting, right? In the family medicine setting, right? Let GP be their partner. Singapore, we have GP partnership, isn't it? Right? We have CHCs, community health centers. We have FMCs, family medicine clinics. Let's train caregivers to kind of operate in that space. Good enough. If that is not the best place for them, or if we don't really fully agree that that's the best place where informal caregivers should operate, then where? So that's the thinking I'd like you to have as you navigate with me on this section. Where should the caregivers be placed? Which part of the healthcare system? And if you like, if it even borders into the social, then health and social as well, where should they be placed? Okay. In that article, they asked you to read that. Which Shah, I think yesterday emphasized, please read chapter 6 rather than the entire 300 over pages, right? That article, that article describes the American system called the current system. You read it, right? It's a failure. People are not accessing healthcare. People complain it's so expensive or it doesn't work for them. And it's fragmented, right? Different parts of healthcare will work, right, on their own, right? And people just do not see healthcare meeting their healthcare needs, as in the care provision meeting their needs, right? We see that. And then they did, I think, a study, right? People were asked what is needed, right? Sorry. People are asked, did a doctor, a nurse, or any healthcare worker ask you what was needed to actually help your care recipient at home? A third of them said yes. Right, next one, right? About 16% or less than a fifth, right, said that a healthcare provider, a health provider, actually asked them what they needed to care for themselves, self-care. Right. Next one, family caregivers, right, must interact with a wide range of providers and navigate within a variety of systems. Now that is what I kind of talked about 1 minute ago. Singapore, we have one health ministry. We are a city state, so there is no difference between federal level, state level, city level. It's just one, right? Right. Hong Kong, you have territories, right? Malaysia, you have states. Right? China, you have provinces, right? Clusters, that's right. Today, now we have 3 clusters. We actually came from 6 clusters, which actually in the past came from disparate hospitals and different groups. Yeah? Yes, we have that. Now, healthcare is kind of rapidly either evolving organically as well as being developed, both, right? The natural as well as the push. Who is there or what is there to help caregivers understand what's going on? That's the third point there. Right? So Xiang Jai talks about, and AIC talks about now 3 health clusters, right? And then they are managed by those 3 bosses of those 3 giants, okay? And then under those giants, there are smaller component hospital, and then within hospital, there are department and so on, right? Who is there to help the caregiver understand the way you work, the way you talk with the doctor 5 years ago about your father's, say, cholesterol condition, is now not going to be the same when you now talk to the hospital or talk to the nurse about now his stroke. Because then we had no cluster. Then we had just hospital. Now we not only have clusters, we have 3, and this cluster may not work with their cluster. Right? Who is there to help caregivers understand this? Right? Perhaps GP, yes, thank you. And some people say GP, understandably so, because primary care is tasked with the responsibility, the noble responsibility, right, to be the go-to place, the first go-to place, right, when one has any ailment. And that is not just restricted to people who need long-term care, but in fact, any other ailment. In fact, today, if we think we have fever and have COVID-19, we are advised to go to a GP first, right? That's why people go to GP, come home, by the third time, then they go to NCI. Right? Now, who is going to help the caregiver understand? If not, do we reasonably expect? Can we reasonably expect a family caregiver, right? Never mind domestic, foreign domestic workers, okay, they don't speak language, fine. But just Singaporeans, just locals, residents, right? Can we reasonably expect that our caregivers, our family members know who to go to for what? That's the third point there, and the fourth point there. Now, the fourth point, older adults seek help from family in making healthcare decisions. Right? But there are two buts. The first but is that, but there's few evidence-based strategies to actually involve these families within the healthcare encounters or within healthcare sectors, as I described. So healthcare can continue to develop, to improve clinical care standards and so on and so forth. We can be gold standard in the world for, say, COVID-19. Right? We can be gold standard in, say, several things, dementia care, for example. Okay? But do the caregivers know? Are they a partner in this gold standard? Do they co-create? Do they see themselves as a part of this health and social care system? That's the question we ask ourselves. In that article, the author says, no, not in the American system. Right? In that article, right, the author says, no, the American system, where here in Singapore we have 3 M's. America, they have Medicaid, right? And what's the other one? Medicare. That's right. To the author, it's a failure. Nobody understands how to navigate that. How you navigate Medicaid, if you come here, but by the time you go to another city, another state, it's a totally different way, right? At the state level, then at the national, federal level, totally different. And then for different service types, from residential to non-residential, within non-residential, community, dementia, so on, all have kind of different ways to administer Medicaid and care, right? So I'm glad in Singapore we have just one city-state. So 3 M's is still the same 3 M's, right? Whether or not that's sufficient is another discussion altogether. But well, at least we know the lingo, right? Today, right? Yeah. So that is the thinking we want to have. Where if we do not create or co-create a healthcare space where informal caregivers are the part of our partner with, then I'm afraid, right? Years down the road, when Singapore becomes not the gold standard but diamond or platinum standard healthcare, we are going to have a totally different group out there, caregivers of aged persons, older persons, who are left in the lurch, who don't know what's going on, who may still be feeling those burdens that this system is supposed to address. And then this system is going to say, we did a great job, but hey, nobody's coming to use our services. We can build and build and build. How many nursing homes by 2030? How many by 2040, 2050? Right? But are people going to use them? When we continue to build more, are people going to use them? When we want people to use them, they must find a service intuitive to their needs, right? I have a handphone, I show it to you. Apple does it, very good comment. You show how slim it is. Then put the razor there, and show you how it kind of separate, and then it's still intact. And then in one of those, you get somebody like a forgetful auntie, older person, take the chopper and use the iPad as a chopping board, and it still works. Right? And then Apple will glorify or magnify the colorful nature, how bright the red is, how bright the yellow is, by actually showing rainbow and temperate regions, right? Countries in the temperate region, the autumn, the fall, right? So people will look at, wow, I want to have that. It's so great. Even though people, I may not have heard of it, now I just see, yes, I want to have it. I will use it, right? It will serve my need and more. When I have it, I'll be happy. Can we have a health and social care in long-term care? When we do this, people might not have heard about that. People might not have known, caregivers might not have heard about, say, even $200 monthly cash payouts, or whether to go to the GP first thing when their patient suffers. But could we find a way to tell caregivers that, look, this is great. When you come here, when you enter the door, here's what you get. And then when you need this, you have that. When you find you are worried about not just the money, but let's say memory and behavioral problems, don't worry, we have this. And here's how we help share. Can we design and then get caregivers to use?
Actually,
yes.
Whether health promotion board can do something about this, what you raise up is really true. I take 30 minutes consultation time for my patients purely because they don't know the service here in Singapore. I'm not born in Singapore, but I try my best to inform them there is an AI ceiling in the hospital, which they don't know, the caregiver, they don't know one-on-one. One, number two, I asked them to go for training for the dementia patient, and they informed me, oh, I am not a registered, even though I'm a daughter, but I'm not a registered caregiver, so I am not entitled to the grant. I was like, stand there and puzzling, have a lot of questions. So which organization in Singapore have all this media support to inform the caregiver, where should they go? I mean, for GP like me, I'm not get paid. I spend my time to explain to them out of good heart. Nobody asked me to do it, but would the government or insurance company do something about that? It's overloaded, actually, the GP. I tell you, I'm really honest to tell you.
And not paid, I'm sure. Time is money to GP and time is caseload to GP, absolutely. Thank you for sharing your experience. It's true, we need two things. So you mentioned health promotion, certainly we need that, right? The media, the telling the information. So that's one piece. But the other piece is this, we need to have something before you can promote, right? The something, the crux of it, the real thing, in Singapore you say the goyo, the secret recipe, if you like, the ingredient. We need to have the ingredient ready so that our health promotion people, ambassadors such as GPs, insurance providers who want to work within the healthcare system can take that further and kind of spread it out. We need to have that. Question now is, to what extent do we have this goyo? Do we have this main ingredient there? That is really what this second part of the seminar is about. The model of care is that thing, the crux of it. We need to get our model right. We need to get our model right. Then it can be understood. If you are not sure what the model is, what it comprises, where is what, and so on, for instance, where the informal caregiver should fit in, what happens if we take the next step? So sometimes we like to, in my own words, pardon my crudeness, wear our underwear outside our pants. We kind of share about, almost to the extent of bragging that we have achieved this. We have turned this pilot into mainstream. Let's invite the minister, cut the ribbon, shake hands, take photo, ding, and then you do this kind of act. Now, I'm not criticizing any organization or anybody there. What I'm saying is, look, we need to make sure we know what we are doing, and this thing, we need to be personally convinced that it is something that is both practically useful as well as good, as well as right to do. Then we can then sort of take the next step. So of course we cannot not have the next step as well, that people won't know. So it is important. I'm saying it both are important, but first of all, we need to get our thing right. There is a comment there. Actually, one challenge they faced previously was understanding of what seniors needs, language barrier, and their inability to navigate the healthcare system. As a healthcare provider, we also cannot check on their benefits because of PDPA, thus creating a problem that they don't know us, and yet we can't reach out to them appropriately. Thank you very much, Ben, on that point. True, yes, that is one challenge. In one of my other slides, when I share about a research study done earlier on, you will see some of the verbatim, verbatim feedback that caregivers and patients gave us regarding the various services. And one of that is, yeah, I don't understand. That's right. And there is this barrier there. How do we break down the PDPA barrier? I mean, first of all, we need to respect, right, such things called PDPA. Right? Before PDPA, we already have the Medical Act, right, where medical records are kept confidential to the patient only, right? But that's way before the PDPA, right? How do we must first understand where these two comes from. The idea that information is sacrosanct. Right? The paradigm or the philosophy, if you like, is that a person's privacy, right, ought to be respected. Right? That not only the medical profession, but all the other various helping professions ought to respect one's privacy, and that may extend to information privacy. Yes.
No, I was just thinking from the last section you talked about, in my personal experience with the old folks at home, actually I found it quite a smooth journey. So maybe my thought is that probably if the family members are literate, they'd be helpful where there's a website where they can go to find out what they can do and so on. But I mean, the first time when my mother-in-law had a hip fracture, it was actually quite smooth because from the hospital, they directed her to go to the St. Luke's home. And from there, they had a daily training to help her improve. And they even said that, okay, you need the FDW, then engage one, and then we will train her. So actually, it was quite a smooth journey. And then even on the last phase of my father-in-law, the husband, the doctor actually just recommended that we should get the community aid to come to bathe him so that it will not embarrass the helper.
Yes, yes, it's true. We get varied experiences. What you shared is kind of a positive and helpful. Then we have ones that are quite lost as well. So I guess your point there is, how do we ensure that the right people get the right thing and everybody's happy, or most people are happy? You can't get everybody. Yeah.
Paul, actually, I raised the same question to last week, because we are supposed in a faith-based profession. We know we need to have the passion to do it, but without the drive, without the motivation, we are overloaded in this profession. I mean, in a sense, can there be something like a trust? Take for an example, come from primary care to hospital care. We are working in a cluster within the trust. We are not paid by each trip reimbursement back to me as a GP, but you pay me as the total performance. We drive, like to cure this sickness, instead of taking 1 month, it turned out to be 2 weeks. So there are cost saving, right? We share that good thing among the community. I will be feeling very awarded in that sense. If that happens, we will do it automatically to tell everybody what you should do as a caregiver, and then I don't mind to give you a helping hand. If that is the way that work as a team,
thank you.
Is it possible here?
It's possible here. I thought about that a few times when I was in AIC. When I wrote that paper on managing mental health in primary care, one of the things that personal lessons I know is, if we have more enlightened GP, the answer is yes. Right? GP tend to work in solo, right? We know that in many places as well as in Singapore. Of course, there's group GP, you know, those Pathway Health and all that, right? Yes, but by and large, more than half of our GPs in Singapore are solo practice, not polyclinics, excluding the polyclinic. So we really don't know what they think. The enlightened persons, thank you very much, like you, right, to say that it's good for everybody. I don't mind spending the extra unpaid hour doing that. I'm sure you don't. And there are big people like that. I know other GPs like that. But so we also have others who simply want to be in the clinic 5 hours, see their caseload and get it over and move on to other things. I can't say that that's wrong, right? So that's the nature of the sector right now in Singapore. GPs are mostly solo and then some group. Think about it now. I'd like to challenge us to think even higher. Beyond the primary care is our informal caregiver. Is our informal caregiver a solo? Let's take a lesson from the GPs. Our informal caregiver operating like a solo GP, like a solo caregiver. Would you say more a yes or no? Okay. Hands up, including people at home. Hands up if you think it's more a yes. Informal caregivers are more like solo. Hands up. Thank you. Thank you very much, people in class. I see 2 at home. Hands up as well. Right? Oh, Ben asked me, sorry, more like a solo GP. That means operating at home. That's the question. Solo GP. Right? Yeah, it's true. Right? Although the primary informal caregiving survey says about 4.5 persons leaving the household, often it's just one person who takes care primarily. That person, half the time, according to that survey, is an FD, as in see to the day-to-day. Right? He or she may not be a decision maker, right? Yes, solo GP, that's right. So caregivers tend to be solo just like GP. So we can perhaps take a lesson from the building up of capacity and capability in the GP or primary care sector. The way that we build up primary care, sometimes, okay, several strategies. One that is very well known is financial incentives, right? Incentivize the clinic. Right? So you subsidize certain things here, subsidize there, right? Like CHARS, right? And then people will come to the clinic. Hopefully when they come, although they're subsidized, but they also end up paying more. So then the clinic also benefit, right? In total, so to speak, right? Right? Sorry, I let the cat out of the bag. Right? So now think about caregiver. Solo caregiver, okay? Think about yes, we have all these subsidies, so we incentivize them. are we really incentivizing them in a way that so that they end up actually providing more than they're incentivized, being incentivized? That's the question here. The $200 home caregiving cash payout, right, that we talked about, for example. Are we really getting more than our money's worth? More than $200 worth of caregiving time and resources? Are we doing that? I'm sure the Singapore government wants that, right? We are very pragmatic. We have a very pragmatic governance policy here. Yes, but are we really getting that? That's the question here. If we can get that, then that can really be, right, a model of informal caregiving, isn't it? Right? We subsidize key areas. These key areas, once subsidized to a certain, once you cross a certain threshold, and we can have research or evaluation studies to find that threshold, that amount. Maybe that threshold will be different from service to service, long-term care, in terms of, say, dementia care or community hospitals. You can find that threshold, right? Perhaps, right, give that amount and perhaps a little more, but that will translate to, right, that will have more multiplier effects, right? That's the idea here. Could we find that? Now, how do we answer that question? We need to do research. Yes. How to do that research, how to get that data is yet another issue, right? Okay, so keep your mind on that question. Okay, very quickly, this particular study, and then we take a break. All right. In this study, the research question was this: why do people who need long-term care do not use them? Choose not to use them. That was the key question. Right? It's published in 2015. So what did they find? They found that in Singapore, this is based on Singapore, 4 service types: nursing home, day rehab center, dementia daycare, and forgot what it is. Community hospital is inside, and home care. Four service types. Right? This was done, and they found that the factors include these. You can read. I won't go through it. It's probably reflective of what is found on the ground. Right? These are the reasons why people choose to use or not use long-term care services in Singapore. Right? Now, I want to highlight just this point here. Perception. How do Singaporeans perceive long-term care at that time? Non-users of long-term care see formal long-term care as unnecessary. No need for it. Right? They are only necessary to replace. Right? To replace. When I can no longer help my father anymore. If not, I will help. I can. Users, on the other hand, say that this long-term care actually adds to my ability to help. So I can help, but this long-term care help me help better. Help me do my caregiving better. Right? 4th point there. Nursing home, last resort. I will never send my dad or my mom to nursing home. But of course, we know the statistics show the opposite, right? Nursing homes are the only service among all the long-term care services in Singapore that is heavily utilized, up to 90% utilization, whereas for all the others, it's about 50%, 40% or less. Just now, you saw in the informal caregiving survey, it was 5% in 2010, right? That's what they found. And lastly, they found that decision-making, when it comes to use or non-use of long-term care, is caregiver-centric. Okay, I'm going to skip that. These are the various plus and minus kind of perceptions which you could read. But I'd like to take us to this slide here. How do families decide? Really, these are the key themes that stood out. Family commitment, family financial resources, availability of other caregivers, availability of time, and the caregiver's perception of long-term care. Right? How weighs those physical, mental, and needs, and even care recipient perception when it comes to you deciding whether or not to use the various long-term care services. This was done, I think, 74 caregiver, care recipient diets, in-depth interviews, not surveys. Right? So the button there, I will just read it. I know I'm not able to give 100% caregiving because my daughter is growing up. As a kid is involved, my priority is definitely my family, even though my dad is my dad, but there are still concerns that I have to make sure that my husband is fine, my family is settled. So the best I can do is to send him for medical checkups, liaise with doctors, and visiting. This is from a caregiver, right, of nursing home service user, Malay, of a lower SES. Just one. I mean, there are several such quotes. No time to show everything. Just illustrators of this idea here regarding families' decision making. So okay, I'll take a pause here. So when we go for break, just want to leave you with this thought that now in the model of care, we have begun to see, at least in Singapore, that decision making done by the family, primary caregiver, and where model of care is concerned, we know that this is very much applied to long-term care. We're not talking about acute health care. All right. And second thing, we know from the informal caregiver survey just now that we saw, right, that our profile of caregivers are really predominantly women. We saw those various, right? And those complaints that they have regarding depression, regarding stress, right? So in Singapore, we tend to see long-term care as a panacea, as like a cure. I mean, fix that. But now they start to realize that yes, we can provide care, but people may not use it. And those are the reasons why they may not